When you picture an ancient Greek warrior strapping on heavy bronze body armor for a battle,
Right.
and then you picture an early anatomist secretly dissecting a human body by candlelight in the Renaissance.
Yeah, quite the image.
And finally, you picture a modern EMT performing this, desperate life-saving procedure with a needle on the side of a highway.
Mm-hmm.
It sounds like we are jumping across completely different universes, doesn't it?
It really does. But the reality is there is a hidden thread tying all of those moments together.
Exactly. And that thread is just buried right inside the language we use to describe our own anatomy.
Yeah, the words we use in medicine are doing a lot more work than just, acting as labels on a chart.
Right.
They actually serve as this permanent historical record. Every time a doctor writes a prescription or logs a surgical note, they are using language that contains thousands of years of shifting human knowledge.
Which is just wild to think about.
It is. You have these ancient misunderstandings, brilliant deductions, and massive medical triumphs, all just baked into a few syllables.
So today, we are decoding that language for you. We are pulling from a massive stack of medical terminology sources to do a deep dive into the human chest and its lining.
Specifically focusing on two foundational roots, which are thoraco and pleuro.
Right. And by the end of this deep dive, you're going to have a shortcut to understanding the really complex, load-bearing vocabulary of the human chest cavity.
We want to help you turn what looks like this, alien medical chart into something completely transparent.
Okay, let's unpack this. We should probably start with the physical real estate of the chest itself, right?
Yep,
Because the anatomical reality of what is inside you is, well, it's wildly different from what most of us picture.
Yeah, the biggest misconception we have to clear up involves the thorax, which is represented by that first root, thoraco.
Uh-huh.
If you ask someone to point to their thorax, they will almost always just tap on their ribs. They view it as a bony cage.
Which makes sense based on how it feels.
Sure, but in medical terminology, the bony cage is merely the container. The thorax is the cage plus absolutely everything packed inside it.
I always think of the thorax like a travel suitcase,
Oh, I like that analogy.
Yeah, like if you tell someone to grab your suitcase at the airport, you don't just mean the hard polycarbonate shell on the outside.
Right, obviously not.
You mean the shell, plus all the clothes, the shoes, the tangled phone chargers, the toiletries, basically everything packed within it.
Exactly. And if your suitcase gets crushed by a baggage handler, the contents are at risk too.
Right, so a thoracic injury isn't just a cracked rib. It means the structural integrity of the container has been breached and everything inside is suddenly vulnerable.
And when a surgeon goes into that suitcase, it is incredibly crowded in there.
Oh, I can imagine.
The thoracic cavity houses both of your lungs, your heart, the great vessels like the aorta and the vena cava, which are pumping massive volumes of blood in and out.
It's busy.
Very. It holds your esophagus, your trachea, the thymus gland, and this really crucial space sitting right between the lungs called the mediastinum.
The mediastinum.
Yeah, which is just packed with fat, lymph nodes, and connective tissue. So when you see a medical term built on thoraco, like thoracic surgery, it refers to an action being taken on that entire complex compartment.
Okay, so that brings us to the second major root we're covering today, which is pleuro. And just as people mistakenly think the thorax is only the bones, there is this widespread assumption that the word pleura just means lung.
Which is a huge trap. Lung tissue is described using completely different roots, specifically pneumono or pulmono.
Okay.
Pleura refers to the pleura itself. This is a thin, very slippery, double-layered serous membrane.
Double layered.
Yes, it coats the inside of the thoracic cavity and then actually folds back over on itself to tightly wrap the outer surface of each lung.
So it's not just a single piece of shrink wrap. We are talking about two distinct layers.
Exactly. You have the visceral pleura, which is fused so tightly to the surface of the lung itself that you literally cannot peel it off. And then you have the parietal pleura, which lines the inner wall of the rib cage, the top of the diaphragm, and the sides of that central mediastinum we talked about.
Okay, so what's between them?
Between those two layers is a microscopic gap called the pleural cavity. Now, in a healthy adult, this space is virtually empty. It contains only a tiny film of lubricating fluid.
How tiny are we talking?
We are talking about maybe 10 to 20 milliliters of fluid total.
Wait, I need to stop you there.
Yeah.
Because 10 to 20 milliliters is basically what, 2 or 3 teaspoons of liquid?
Roughly, yeah.
How is it mechanically possible that this tiny amount of fluid is enough to prevent friction damage? I mean, we breathe roughly 12 to 20 times a minute.
That's great.
That adds up to over 20,000 breaths a day, every single day, for decades.
Right.
Without lubrication, our expanding lungs would just rub themselves completely raw against the rough inner surface of our ribs.
Yeah, it sounds impossible, but the bioengineering at play is spectacular. That microscopic amount of fluid does two things simultaneously. First, it provides just enough slip so the visceral layer on the lung glides friction-free against the parietal layer on the chest wall.
Makes sense.
Second, and honestly more importantly, it creates intense surface tension.
Surface tension, like water.
Exactly. Think of a wet glass resting on a smooth coaster. The water makes it really easy to slide the glass around, right?
Yeah, you can just push it across the table.
But if you try to pull the glass straight up, the water acts like a suction cup holding them together. That fluid creates a negative pressure vacuum.
Oh, wow.
So when the chest wall expands during inhalation, the suction from that fluid actually pulls the lung open with it.
That is fascinating.
Yeah.
But it makes me wonder, if this double-layered membrane is so incredibly thin and the fluid between it is just a few teaspoons, how did anyone in the ancient world even know it was there to name it?
Well, they didn't have microscopes or modern imaging, obviously.
Right, so how did they see it?
What's fascinating here is that ancient physicians did not know it existed at all.
Wait, really?
Really. The definitions of these words have morphed entirely over the centuries. Going all the way back to Homeric and classical Greek, the word thorax did not mean a body cavity.
What do it mean?
It meant a breastplate or a cuirass. It was a literal physical piece of bronze or leather armor worn into battle.
Oh, okay.
Over many generations, the word was just extended metaphorically to describe the body part that the armor protected.
So they took the name of the shield and basically applied it to the thing being shielded.
Exactly.
Did the same thing happen with the pleura?
Basically, yeah. In ancient Greek, pleura originally meant a rib, or just the side of the body in general. Sailors even used the word to describe the wooden ribs of a ship's hull.
Oh, that's wild.
Yeah, it had nothing to do with the biological double-layered membrane. If you look the medical texts of Hippocrates from the 5th century BCE, his physicians frequently diagnosed a condition they called pleuritis.
Which sounds like inflammation of the pleura.
Right, but to them, they were just diagnosing a sharp stabbing pain in the side of the chest. They had absolutely no concept of a discrete, fluid-filled sac inside the ribs.
So they were essentially diagnosing a geographic region rather than a specific physical structure.
Exactly.
It's like trying to navigate a city using only cardinal directions,
Yeah.
Tell someone, go to the north side of town.
But you don't have a street address.
Exactly. You know generally where the problem is, but you don't have the map to pinpoint the exact house.
And they were operating without that precise street map for over a millennium.
1,000 years.
Yeah. A massive reason for this blind spot was a strict prohibition against human dissection in many ancient cultures.
Ah, right. Taboo.
Because physicians couldn't look inside human bodies, they relied blindly on the teachings of Galen, who was this wildly influential physician from the 2nd century CE.
Okay.
Galen mapped out his anatomy by dissecting animals, specifically pigs and Barbary macaques, and he just assumed human internal anatomy was a perfect copy.
Wait, I have to push back on that. Because doctors back then were treating wounded soldiers and gladiators. They were constantly dealing with chest wounds.
True.
Didn't any battlefield surgeon look inside a human chest cavity and realize, hey, this looks completely different than a pig?
You would think so, right? But anatomical dogma was incredibly powerful back then.
How powerful?
When battlefield surgeons saw discrepancies between a wounded human and Galen's texts, they often assumed the human body had simply degenerated since Galen's time, or that the specific patient was deformed.
Wow.
Yeah, questioning the ancient texts was basically academic heresy.
So the map was considered perfect, meaning the territory itself must be wrong?
Precisely. The shattering of that dogma didn't happen until 1543. That is when a brilliant anatomist named Andreas Vesalius published De Humani Corporis Fabrica.
That's a famous text.
It is. It was this monumental, systematic atlas of human anatomy based on actual methodical human dissections. Vesalius finally delivered the accurate street map.
It actually looked.
Right. He gave the medical world its first meticulously illustrated descriptions of the true contents of the thoracic cavity, finally replacing Galen's animal-based fictions.
Okay, so once Vesalius proved what the internal structures actually looked like, the medical vocabulary had to adapt. The word pleura went from being a vague geographical term, meaning the side of the body, to denoting the microscopic tissue level, the histological structure that wraps the lung.
Exactly. The language tightened as the science improved.
Makes sense.
Eventually, the international medical community realized they needed a universally standardized system. I mean, you couldn't have doctors in Paris using different anatomical terms than doctors in London.
That would be a nightmare.
Right. So in 1895, an agreement called the Basel Nomina Anatomica was published, followed much later by the Terminologia Anatomica.
Okay.
These agreements locked in official Latin and Greek terms for every structure in the human body. They established this Lego-like system of combining forms.
Lego-like.
Yeah, a root word, like thoraco or pleuro, gives you the what, and a suffix gives you the action or condition.
Here's where it gets really interesting, because combining these roots and suffixes isn't just about passing some medical vocabulary test. These compound words describe intense, real-world physiological crises.
They do.
Take the term pneumothorax. If we break it down, pneumo means air, and thorax means the chest cavity. So it is literally air trapped in the pleural space.
And because that pleural space normally relies on a negative pressure vacuum to keep the lungs suctioned to the chest wall, any air leaking into that gap destroys the vacuum entirely.
And the lung just drops.
Right, the lung on that side instantly collapses. A spontaneous pneumothorax classically strikes a highly specific demographic, actually.
Oh, really?
Tall, thin young men, usually in their late teens to 20s, particularly those who smoke.
With them.
It happens when tiny, blister-like air sacs on the very top surface of the lung, these are called blebs, suddenly rupture, leaking air into the cavity.
And the stakes go up exponentially if it develops into a tension pneumothorax.
Okay.
That changes it from a painful condition into a full-blown code blue emergency.
Absolutely. In a tension pneumothorax, the rupture in the lung acts like a one-way valve.
Okay.
So every time the patient inhales, more air is forced into the pleural cavity, but it cannot escape when they exhale. The pressure builds relentlessly.
Which keeps filling up.
Right. It builds so much that the trapped air physically pushes the collapsed lung, the heart, and the massive blood vessels away from the center of the chest.
Oh, man.
It actually kinks the superior vena cava, cutting off blood return to the heart, leading rapidly to cardiac arrest.
So to stop that pressure from crushing the heart, an EMT or a trauma doctor has to perform a needle decompression.
Yes.
They literally stab a hollow needle through the ribs directly into the pleural space, allowing the trapped air to hiss out and relieve the pressure, which perfectly sets up another crucial medical term, thoracentesis.
Right, exactly.
Thoraco meaning chest, and the suffix centesis meaning a surgical puncture to aspirate or remove fluid.
A thoracentesis involves inserting a needle or catheter through the chest wall to drain fluid or air from the pleural space.
Right.
It can be used diagnostically to pull a fluid sample to figure out why the patient is sick, or therapeutically to give them immense relief because, liters of fluid can build up and physically crush the lung.
Right.
But there is a strict clinical rule when performing this. A physician should generally not remove more than 1.0 to 1.5 liters of fluid in a single rapid session.
But wait, if the fluid is crushing the lung and the patient is struggling to breathe, why in the world would you stop draining it? Shouldn't the goal be to empty the space completely so the lung can inflate?
You'd think so, but draining it too rapidly triggers a paradoxical crisis known as re-expansion pulmonary edema.
Re-expansion pulmonary edema, what does that mean?
Well, if the lung has been severely compressed by fluid for days or weeks, the tissue adapts to being compacted. If you drain all the fluid at once, the negative pressure suddenly returns and violently yanks the lung open.
I picture this like a dry, crushed kitchen sponge.
Yeah, that's a good way to look at it.
Like, if you have a sponge squeeze incredibly tight in your fist, and you certainly let it spring open while it's sitting next to water, it instantly sucks up everything around it. It floods itself.
Exactly. And because that biological sponge springs open so violently, the sudden mechanical stretch actually tears the microscopic blood vessels inside the lung.
The capillaries burst.
Yes. The lung tissue instantly floods with its own blood and plasma. You drain fluid from the outside of the lung only to cause the inside of the lung to drown itself.
Wow.
It perfectly highlights why rote memorization of terms like thoracentesis is completely useless without understanding the physical mechanics behind them.
Even with this exact vocabulary and an understanding of the mechanics, doctors historically still fell into massive diagnostic traps. Having a precise word doesn't always guarantee a precise diagnosis, does it?
No, it doesn't. And this raises an important question about how medical language can inadvertently camouflage a patient's true illness.
How so?
For the majority of modern medical history, the word pleurisy was used loosely as a catch-all diagnosis. If a patient came in with sharp chest pain that spiked every time they took a breath, the doctor just wrote down pleurisy.
Right.
But before the invention of X-rays or CT scans, doctors had no reliable way to distinguish between pleuritic pain caused by pneumonia, a silent pulmonary embolism, early-stage tuberculosis, or even just a violently pulled muscle.
The word was basically just a placeholder for something in the chest hurts.
Exactly.
The danger there is that if you write down pleurisy, the doctor assumes they've found the disease and stops looking.
Which is very dangerous.
Right. So modern medicine had to intervene and redefine the term. Pleurisy, or pleuritis, meaning inflammation of the pleura, is now strictly taught as a symptom. Right. It's a sign of an underlying process.
Yes, it points to a culprit, like an infection or a tumor, forcing the clinician to keep hunting.
So what does this all mean? We cleaned up the pleurisy trap, but the vocabulary is still full of confusing overlap.
Yeah.
Thoraco isn't the only root word for the chest. We actually have 3 competing roots that seem to describe the exact same region.
We do.
We have thoraco, which we established as the internal cavity, but then we also have pectoro and stetho. Why do we tolerate 3 different roots for one body part? It seems designed to torture medical students.
It looks like pure redundancy, I know, but it actually provides highly specific contextual nuance.
Okay, let's hear it.
Pectoro, which you hear in words like your pectoralis muscles or a pectoral fin on a fish, refers specifically to the front chest wall and its surface musculature.
So the outside.
Right. It describes the anatomy you can palpate or touch from the outside. Stetho, on the other hand, conceptualizes the chest purely as a site of listening, of auscultation.
Ah, that's where we get the word stethoscope.
Exactly. René Laennec invented the first stethoscope in 1816.
Before that, they just used their ears, right?
Yeah, prior to that, doctors listened to the heart by pressing their ear directly against the patient's chest.
Awkward.
Very. Laennec was actually examining a young female patient and felt that direct physical contact was improper. So he remembered that sound travels perfectly through solid objects, and he rolled up a notebook into a tight paper cylinder, placed one end on her chest and the other to his ear, and the stethoscope was born.
That is brilliant.
So you see, a thoracic surgeon needs thoraco to describe opening the cavity, a physical therapist needs pectoro to describe a torn muscle, and a physician needs stetho to describe listening to the echoes inside. The distinction is deeply functional.
I love that.
Yeah.
And when it comes to the thoracic surgeons actually opening that cavity, the historical timeline is filled with staggering risks.
Oh, absolutely.
In 1933, a surgeon named Dr. Everett Graham performed the first successful pneumonectomy. He completely removed an entire lung to treat a cancerous tumor.
It is difficult to overstate how dangerous that was in 1933. They didn't have modern imaging, they didn't have advanced mechanical ventilators or targeted antibiotics.
It was flying blind.
Going into the thorax was highly lethal. Furthermore, his patient was a fellow physician, Dr. James Gilmore. But Graham managed to remove the cancerous lung, tie off the massive blood vessels, and close the chest.
And the operation proved thoracic cancer surgery was survivable, largely because Gilmore lived for decades after the procedure.
Right.
But the dark irony of that story is staggering. At the time of the surgery, Everett Graham was highly skeptical of the theory that cigarette smoking caused lung cancer.
Yeah, he was a very heavy smoker himself.
Which was normal back then.
True. But as he conducted more epidemiological research in the years following the surgery, Graham realized his error. The data was undeniable.
So what did he do?
He became a fierce, pioneering advocate, warning the public about the dangers of tobacco. But unfortunately, the damage to his own body was done. In a tragic twist of medical history, Graham died of aggressive lung cancer.
While the patient whose lung he had removed outlived him by nearly 30 years.
Exactly.
It is an incredibly grim reminder of the stakes of thoracic medicine.
Ah.
But the tools they developed during that era stand the test of time. There are diagnostic protocols from decades ago that remain the absolute gold standard today, right? Like Light's criteria.
Yes, Light's criteria. Published in 1972 by a pulmonologist named Richard Light. This is a set of biochemical rules used to analyze the fluid drained during a thoracentesis.
Okay.
It allows a physician to instantly classify if a pleural effusion is a transudate or an exudate.
Explain the mechanism behind that, because it isn't just about memorizing fluid types. It tells the doctor exactly what is breaking down inside the patient.
Right. Think of the pleural membrane as a microscopic sieve that filters fluid.
A sieve. Okay.
When a patient has an infection, like pneumonia or a tumor, the resulting inflammation physically damages that sieve. The blood vessels become inflamed and leaky, allowing massive, heavy protein molecules to spill through the torn sieve into the pleural cavity.
And that's an exudate.
Yes, Light's criteria detects those high protein levels, classifying it as an exudate.
And what if the sieve isn't torn? What is a transudate?
A transudate occurs when the sieve is perfectly healthy, but the patient has a condition like congestive heart failure.
Okay, so the heart is the problem.
Right. The failing heart creates a massive backlog of pressure in the vascular system. It acts like a pressure washer, violently forcing pure, watery fluid through the tight sieve, leaving the heavy proteins behind.
Oh, I see.
By simply measuring the protein and enzyme levels in the fluid, Light's criteria tells the doctor if they're dealing with leaky, inflamed vessels or a pressure washer heart failure.
It acts like an old master key that miraculously still opens modern diagnostic doors.
It really does.
Of course, while the fluid chemistry hasn't changed, how surgeons physically access the thorax has been revolutionized. For most of the 20th century, accessing the lung required an open thoracotomy, which is a literal cutting into the thorax.
And it was a brutal approach. To get past the bony container, surgeons had to make massive incisions, mechanically spread the ribs apart with steel retractors, or even saw through and remove a rib entirely.
That sounds agonizing.
The recovery was terrible. But starting in the 1990s, the field shifted heavily toward VATs. Yeah, video-assisted thoracoscopic surgery. Surgeons now make tiny incisions, inserting a high-definition camera, thoracoscope, and long, specialized instruments.
Just much less invasive.
They can remove tumors and resect lung tissue with a fraction of the tissue damage, dramatically reducing the patient's pain and recovery time.
So if we pull all of this together, why does understanding this vocabulary actually matter to you listening to this right now? This deep dive is about far more than just winning points at medical trivia.
Oh, absolutely. If we connect this to the bigger picture, this vocabulary is the foundation of modern public health communication.
How so?
Think back to the sheer volume of data during the height of the COVID-19 pandemic.
Right.
Complications of severe viral pneumonia, like pleural effusions filling with fluid or secondary pneumothoraces collapsing lungs, were tracked on thousands of CT scans globally. Knowing how to break down these anatomical roots and surgical suffixes is exactly how hospitals, researchers, and epidemiologists coordinate care.
It takes the intimidating, opaque language of medicine and makes it transparent. If you know that pneumo means air and thorax is the chest cavity, you aren't intimidated by the chart anymore.
Exactly.
For nursing students facing exams, EMTs in the field, or anyone who's just insanely curious about how their own machinery operates, this vocabulary is basically your master decoder ring.
It allows you to peer inside the human body and recognize that these complex terms are just, elegant descriptions of brilliant mechanical logic.
As we wrap up, I want to leave you with one final mind-bending anatomical fact to mull over. We spent this entire time talking about the pleura, this ingenious, double-layered, fluid-cushioned vacuum membrane that keeps our lungs from destroying themselves against our ribs.
Right.
Well, you have another, nearly identical double-layered membrane sitting in your abdomen. It's called the peritoneum, and it wraps your digestive organs.
And the pleura and the peritoneum are in entirely different locations. They suffer from entirely different diseases, and doctors use completely different vocabularies to describe them.
Yet they share the exact same structural design. Why? Because millions of years ago in the womb, both of those membranes evolved from the exact same hollow bubble of embryonic tissue known as the coalomic cavity.
It's amazing.
It is the exact same biological blueprint. It just severed in half by the diaphragm and repurposed for a completely different suitcase of organs. It leaves you wondering, what other parts of the human body are just ancient repurposed anatomical designs waiting for you to decode them.
The human body is just packed with those hidden evolutionary echoes.
It truly is. So next time you pack a suitcase or see a piece of ancient armor in a museum, remember the thorax. The container, the delicate contents inside, and the incredible evolving language that connects it all.